Good morning, everyone. I'd like to welcome you to Grand Rounds today with the Heart Foundation. I first want to thank our pharmaceutical sponsors, Janssen and Eli Lilly, for supporting, for their ongoing support of this meeting. As we traditionally do, we introduce just a research study prior to getting started, and I thought we're going to be starting this study here very soon, and it was timely given Paige's talk. And the title of this upcoming research study that hopefully is going to start next month is called SGLT2 Inhibition Improves Left Ventricular Function and Reduces Adverse Left Ventricular Remodeling in High-Risk Patients with Microvascular Obstruction Following ST Elevation Myocardial Infarction. That's quite a mouthful. So to be in this study, these will be patients with their first STEMIs, with have at least mild LV dysfunction and elevated, moderately elevated troponin, with an infarct size greater than 10% of their left ventricle and evidence of MVO on cardiac MRI that's greater than 10% of infarct size. In this study, which is funded by the Abbott Northwestern Hospital Foundation and the Minneapolis Heart Institute Foundation, will randomize 80 patients to 10 milligrams of dapagliflozin versus placebo for 6 months. And they'll have cardiac MRIs at baseline before they go home following their PCI for their STEMI, and then again at 6 months. And the endpoints are MRI based, which are changes in LV function, volume, infarct size, and LV mass over 6 months. And the patients will be followed for cardiac MACE for 1 year. And then briefly, what's the rationale for this? Well, this is some data we published about a couple years ago showing the effects of microvascular obstruction on STEMI patients on changes in left ventricular ejection fraction and volumes at 6 months in our time trial. And you can see that if you had MVO, that you're at 6 months, that you had significant adverse left ventricular remodeling compared to those patients that did not have MVO. And then in the bottom right corner shows the change in ejection fraction, that if you had MVO, you had no improvement or no recovery of your heart function, whereas if you did not have MVO, then you had a 6% absolute improvement in your ejection fraction. So the reason we're doing this is just some recent MRI data from SGLT2 sub-studies showing that this is an empagliflozin showing significant differences in left ventricular remodeling and ejection fraction in those patients randomized to SGLT2. And so this is just 80 patients, and they showed statistically significance. And this is more than we've ever seen in any of our stem cell studies. So these drugs that Paige are going to talk about are really powerful, and hopeful that this will find a new niche for these drugs in our high-risk STEMI patients. So I'll conclude. Any questions? You know where to find me. Thanks.
Even better than stem cells.
No, isn't it?
Good morning, everyone, and welcome to the Monday morning post-Thanksgiving Grand Rounds. Hope everyone's belt buckles are suitably adjusted. Now, this morning I have the privilege of introducing Paige Skelton as our speaker. Paige, I think almost everyone knows Paige and her talents from working with her here in the hospital. She's distinguished herself as an excellent clinical pharmacist and is very available to all of us to answer questions. Paige is a graduate of the University of Minnesota in 2016, and then she spent 2 years here at Abbott, specializing most recently in heart failure and its management, including all aspects of heart failure, from just pharmacologic to left ventricular assist device and all in between. Paige spoke to us a year ago. She had great grand rounds on supplements in cardiovascular disease. And she enjoys in her free time horse riding. And I once interrupted Paige on her vacation in Jamaica, where she returned a call to me to answer a silly question I had on a drug. So that shows you how available she is. And we welcome you back for another great grand rounds on a topic of interest to all of us. Thank you.
Perfect, thank you. All right, good morning, everybody. Thanks for joining us on this early Monday morning after Thanksgiving. Hopefully the turkey has worn off and everyone's awake this morning. I'll try to keep everyone awake as we go on as well. So today we're going to be talking about finding the sweet spot in prescribing SGLT2 inhibitors in heart failure. That's my best attempt at a clever title, so hopefully that draws you in there. I have no disclosures. The objectives for today's presentation, first and foremost, my main objective for this presentation is really to get everyone that's here in person or tuning in comfortable with this class of medications. Historically, this class has been used for type 2 diabetes, and now with recent literature, we're really looking at expanding where we're using these medications. And really, when we dial down and look at this class of medications, they're really quite straightforward and pretty simple. And so I hope that by the end of this presentation, everyone is more comfortable with this class. So we'll first start by looking at the pharmacology of SGLT2 inhibitors. We'll next look at reviewing the clinical trials evaluating the use of SGLT2 inhibitors in heart failure patients. And so I was kind of given a little tidbit from a few physicians that they didn't want this to be super clinical trial and data heavy and more on the practicality of how we use these medications, how we prescribe them and monitor them. So I tried to keep the literature piece more on the short side. Then we'll discuss how this recent data has now been incorporated into updated guidelines and looking at now how we consider SGLT2 inhibitors, really one of our main pillars of heart failure treatment. And then also we'll finalize or finish by looking at illustrating safe prescribing and follow-up of SGLT2 inhibitors. Here is a list of abbreviations that will be used throughout the study or throughout the presentation. Most of these should be known to all of you guys here. So maybe one to point out is the lowercase h, HF is hospitalization for heart failure, but otherwise most of these are pretty common. So we'll start by looking at the background. So the mechanism of these medications is that SGLT2 inhibitors inhibit the SGLT2, thus reducing reabsorption of filtered glucose and promoting urinary glucose excretion. So as you can see by looking at kind of the blanket mechanism here, how these medications were primarily used for type 2 diabetes and reducing blood sugars, and thus reducing hemoglobin A1Cs. So when we look at the medications in this class, we have 4 medications. So we have all of what I like to refer to as the gliflozins. One nice thing within pharmacy and pharmacology is the naming of these medications. So dapagliflozin, or otherwise known as Farxiga, empagliflozin, which is Jardiance, canagliflozin, which is Invokana, and then ertugliflozin, which is Steglatro. The first 3 here, so dapagliflozin, empagliflozin, and canagliflozin are all on formulary here at Abbott Northwestern. So if you have a patient in the hospital that you'd like to start on an SGLT2 inhibitor or one that maybe was on one of these SGLT2 inhibitors prior to admission, it will be okay to continue these as they are on formulary. So I'm more of a visual learner, so I wanted to include a few pictures of kind of the mechanism and how these SGLT2 inhibitors work. Especially as we look at how do they really benefit us with our cardiovascular patients. So you can see here that the SGLT2 inhibitors work within the proximal tubule, reducing glucose and sodium reabsorption. And with that, you get the increased urinary excretion of excess glucose. So this mechanism of action, when we're talking specifically in terms of the cardiovascular benefit, can cause diuresis, natriuresis, a reduction in the hemoglobin A1C. There is weight loss benefits with SGLT2 inhibitors. Across most of the studies, they found on average about a 3 kilogram weight loss. So kind of in the scale of diabetes medications, I would say it's right about in the middle. So better than weight neutral, but maybe not as good as our GLP-1 agonists, for example. And then there's also a mild reduction in systolic blood pressure as well. So again, looking kind of at the mechanisms of the cardiovascular benefit. So we're lowering the glucose, providing weight loss, reductions in blood pressure without an increase in heart rate, decreases arterial stiffness and vascular resistance, increases our HDL or our good cholesterol, reduces albuminuria, and improved renal function. So there are some renal benefits with these medications as well. And then when we're talking about the heart failure and the cardiovascular space, really that osmotic diuresis and natriuresis is where I think we really see the benefit with these medications. And then lastly, one more picture just kind of ties in all together various organs that the SGLT2 inhibitors can potentially have an effect on. So within the middle, you can see here with the heart, we get decreased preload and afterload, decreased hypertrophy and decreased fibrosis. Another important one to look at is the kidneys, as we do have quite a bit of data with chronic kidney disease. And then also liver, pancreas, blood vessels, blood plasma, and adipose tissue. So I think when these medications came out, specifically within the diabetes area, that was just kind of the tip of the iceberg until we kind of really started to learn more about these medications and the benefits that they can have. So next I have just a short little poll question here. So this was actually a question that was asked by the American College of Cardiology earlier this year in 2021. So a little bit earlier in the SGLT2 inhibitor space within the cardiovascular world. And so the question they asked is, should cardiologists take the lead in prescribing SGLT2 inhibitors in patients with heart failure? So A is yes for most patients who meet FDA indications for heart failure, regardless of the presence of diabetes. B, yes for most patients without diabetes who meet FDA indications for heart failure. And C, no, it should be started by their primary care physician or a subspecialist like an endocrinologist or a nephrologist. And so this poll actually earlier this year showed that 67% of cardiologists voted A, so about 2/3. 16% voted for B, and then 17% voted for C. And I think if we were to kind of redistribute this poll later this year now, at the end of 2021, I think we would find that there's more comfort with prescribing these medications and that the amount of people answering for A would be a lot higher and less, I would say, for C. So again, hopefully throughout this presentation, we gain some comfort. So kind of a follow-up question to that poll was, where were people kind of hesitating to prescribe SGLT2 inhibitors? So 26% said that there was a difficult approval process or cost to the patient. I haven't seen that in practice. I know we have Sam here in the audience, and we'll talk later in the presentation about insurance and coverage, but really with these medications, we're having no issues in terms of requiring prior authorizations or high dollar copays, things like that. So I think it helped that they were already around for diabetes, so they're already on many insurance formularies. 1/4 or 25% of physicians said they lacked experience with SGLT2 inhibitors, which is rightfully so. Typically in the past, cardiologists weren't really managing diabetes, and so probably weren't prescribing SGLT2 inhibitors. So again, hopefully throughout this presentation, you guys will become more comfortable and more confident. Overall pill burden, I think this is something we always have to keep in mind, especially within our HFrEF or reduced ejection fraction population, where we already have medications that we're prescribing, like our ACE, ARB, or ARNI, or beta blocker, our aldosterone antagonists, our loop diuretics. Now we're adding in an SGLT2 inhibitor. So we do need to think about overall pill burden and cost to the patient when we're prescribing an additional drug class or medication. 30% of physicians, rightfully so, were concerned about hypoglycemia and needing to adjust baseline diabetic medications that were prescribed by other providers. I think we're always kind of worried about stepping on other specialties' toes and not wanting to adjust another medication that we didn't necessarily start ourselves. So we'll kind of talk more about that. There is concern for side effects and having to counsel on the urogenital infections or urinary tract infections and yeast infections. So we'll also discuss more of that. And then also 4% said just a general practice to avoid early adoption of newly approved therapies. I don't really have a lot to say on that one because that's just silly to me. So we'll transition into looking at the FDA approved indications. So I wanted to keep this more straightforward in terms of the cardiovascular space and the chronic kidney disease space. So as you guys know, all 4 medications within this class are FDA approved for hyperglycemia or type 2 diabetes. So that's kind of where they originally came about. Since then, we've had really good data in our heart failure with a reduced ejection fraction. So both Farxiga and Jardiance are FDA approved for HFrEF. Just recently here this year, we had the Emperor Preserved trial looking at Jardiance. And so the FDA has granted breakthrough therapy for the designation of Jardiance for the treatment of HFpEF. And this is actually the first drug in this class within the SGLT2 inhibitor class to get FDA approval for HFpEF. So this is actually pretty exciting. As many of us know in this room, HFpEF, I feel like, is kind of the forgotten condition. We don't really have medications that have really shown clinical benefit to the extent that we have within the HFrEF space. So we'll talk more about that HFpEF trial with the Emperor Preserved. With chronic kidney disease, we have Farxiga being FDA approved as well. And so just kind of looking at this table, I chose, for the sake of time, to mostly focus for the rest of this presentation on Farxiga and Jardiance. Nothing against Invokana or Steglatro, but just focusing on the heart failure indications and the data that's available. We'll mostly now be talking about Farxiga and Jardiance. So looking at a little bit of a clinical trial overview here, I just wanted to put these together on a table so you can kind of see what's out. So looking at the HFrEF patient population, we have the AHF trial that was using Farxiga that was completed in September of 2020. And then we also had the Emperor Reduced trial that was completed this year in May of 2021. Within that HFpEF patient population, we have the Preserved HF trial, which was completed this month and enrolled roughly 300 patients to dapagliflozin 10 milligrams versus placebo. So this was just a short 12-week study that was mostly looking at disease-specific biomarkers, so NT-proBNP, BNP, symptoms, health status, and quality of life in patients with HFpEF. And then we also have the DELIVER trial. And so the DELIVER trial is, let's see if I can move my notes here, a phase 3 trial that will have a much larger patient population. So this will be looking at roughly 6,000 patients that will be on Farxiga. With HFpEF, with Jardiance, as we talked about, we have that Emperor Preserved trial that was just published this year that was a positive study as well. And so we'll elaborate more on that here shortly. There's also some interesting data out there looking at acute heart failure patients. So we have the DAPA-ACT-HF TIMI 68. So that is not yet completed. It's estimated to be completed in Q2 of 2023. And then we also have the Impulse trial with Jardiance that's was completed in June of this year and was actually just presented at AHA this year. That was also a positive study. Next, the acute MI space. So kind of going off a little bit of what Dr. Traverse was just talking about. So with Farxiga, we have the DAPA-MI trial. This one, as well as the IMPACT-MI trials, are currently ongoing and will be completed in 2023. And these trials are looking at dapagliflozin or empagliflozin versus placebo in patients with an MI for prevention of hospitalization for heart failure or cardiovascular death. And then lastly, looking at the chronic kidney disease space, so we have the DAPA-CKD trial, which was completed in June of last year, and that showed that dapagliflozin versus placebo reduced the primary composite outcome of greater than 50% sustained decline in their GFR or reaching end-stage renal disease or cardiovascular death or renal death. And then very similar, the EMPA kidney trial is still ongoing, estimated to be completed next year in 2022. And that one is looking at empagliflozin versus placebo and its effect on chronic kidney disease progression and cardiovascular disease death in patients with pre-existing kidney disease. So a lot going on in this space. As you can see, a lot of good literature to come that will continue to add to our knowledge base with this class of medications. So looking at the heart failure reduced ejection fraction trials, this is probably where most people have heard about the SGLT2 inhibitors, as this is, I would say, the quote-unquote oldest data in terms of the cardiovascular uses of these medications. And so looking at the DAPA-HF and the EMPEROR reduced, these trials were both very similar. One nice thing about looking at these two medications when we're talking about cardiovascular disease is if you can remember 10 milligrams, that is usually your dose. And so when we're starting dapagliflozin, we're starting at 10, and we're usually staying at 10. If we're using empagliflozin or Jardiance, we're usually starting at 10 and staying at 10. With that being said, if you have a patient that also has type 2 diabetes that needs the additional blood glucose control, you can increase the empagliflozin or Jardiance up to 25 milligrams. But when you look at these two trials, they're very similar. So they were adults age greater than or equal to 18 years of age, New York Heart Association class 2 through 4, with a left ventricular ejection fraction less than or equal to 40%. With the DAPA trial, they use a GFR cutoff of 30, where with the empagliflozin trial, they use their cutoff as 20. And then both trials had roughly 50% of patients that had type 2 diabetes. When looking at the exclusion criteria, you can see that both trials excluded patients that had a previous MI, unstable angina, cardiovascular procedure, CABG, stroke, TIA within the past 90 days or 3 months. This was mostly to kind of eliminate patients that had an incident that would cause a decrement in their ejection fraction that might improve in the short term purely because of the intervention that they received versus receiving the drug. So then you can see there's also blood pressure cutoffs here. They excluded patients with symptomatic hypotension, type 1 diabetes, and then recent treatment or intolerance to an SGLT2 inhibitor. So I'll just kind of point out here too that here we use systolic blood pressure cutoffs and exclude patients if their blood pressure is too low, or if they've had symptomatic hypotension, or if they haven't tolerated an SGLT2 inhibitor in the past. So keeping that in mind, that a lot of these studies kind of pre-selected patients for these studies that are gonna do well in the studies. So this isn't our typical patient, you know, coming into heart failure clinic or coming into the hospital. So in clinical practice, we kind of see a little bit more than I think they did in the studies in terms of adverse side effects. The primary outcome for DAPA was looking at a composite of worsening heart failure or cardiovascular death, and for EMPEROR reduced, looking at a composite of cardiovascular death or hospitalization for worsening heart failure. Both of these trials followed patients for about a median of 1.5 years. Looking at the preserved ejection fraction trials, so again, the EMPEROR preserved is currently finished and has been published, whereas the DELIVER trial is still ongoing. We'll see those results here hopefully within the next few months, early in 2022. So EMPEROR preserved looked at, again, empagliflozin 10 milligrams, and DELIVER is looking at DAPA 10 milligrams. So if you can remember 10 milligrams, again, you know how to dose SGLT2 inhibitors in heart failure. So a little bit different in terms of the age populations for these studies. So EMPEROR looked at all adults 18 and older, where DELIVER is looking at adults age 40 years of age and older. Again, we're looking at New York Heart Association class 2 through 4 and stable heart failure. Both are looking at patients with evidence of structural heart disease. And you can kind of see here that the GFR cutoffs are a little bit different between the trials. Again, So Deliver with dapagliflozin has a cutoff of 25, where Emperor with empagliflozin has a cutoff of 20. And then again, both kind of have their way of tweezing out kind of our acute heart failure patients. So whether they're off IV heart failure therapies for 24 hours or no episodes of acute decompensated heart failure within a week. Both of these will be pretty large trials, around 6,000 patients, following them for over 3 years. And looking at their primary outcomes with Emperor preserved as time to first occurrence of any component of the composite of cardiovascular death or hospitalizations for heart failure. And it's important to note that both of these trials too will have patients on kind of standard of care treatment for background therapies, which if you asked 20 physicians what standard of care is for HFpEF, you probably get 20 different answers. So just to elaborate a little bit on the Emperor Preserved, since this is the new kid on the block with HFpEF. So again, we're looking at empagliflozin, 10 milligrams daily. The primary outcome was a composite of cardiovascular death or hospitalization for heart failure over 26 months. So in the empagliflozin group, the primary outcome was observed in 13.8% of patients, where in the placebo group it was 17.1%, so showing statistical significance. And then the secondary outcomes, hospitalization for heart failure, 8.6% in the empagliflozin group versus 11.8% in the placebo group. So again, showing statistical significance. And death from cardiovascular causes, there was still a reduction in the empagliflozin group was 7.3% versus 8.2% in placebo. So this one was not statistically significant. So you'll kind of see a common theme among the SGLT2 inhibitor data, where what's really driving these outcomes is the hospitalization for heart failure component. So that is the Emperor Preserved trial. And then lastly, before I put everyone to sleep, we'll talk about the acute heart failure trials, just because this is obviously a very exciting space, and we hear everyone in this room deals with treating patients with acute heart failure. And so we have the DAPA-ACT-HF TIMI 68 and the Impulse trials. So again, if I sound like a broken record, if you can remember 10 milligrams, you know how to dose the SGLT2 inhibitors. And so with the DAPA-ACT-HF, the treatment timing is from 24 hours to 7 days of admission until 60 days. And then for Impulse with empagliflozin, within 24 hours to day 5 of admission until 90 days. So really trying to capture that more acute time frame. So again, very similar. We're looking at adults age 18 years of age or older, hospitalized for acute heart failure. One thing is the DAPA trial is looking at ejection fractions less than 40%, where the Impulse trial is looking at any ejection fraction. And you can see here, again, a little bit differences with the GFR cutoffs. The Impulse trial is a little bit smaller with about 530 patients, where the DAPA trial is looking at more around 2,000 patients. So with these, we're really looking to, again, with the cardiovascular outcomes, time to first occurrence of cardiovascular death or worsening heart failure. And then the Impulse trial also has some endpoints in there, like their Kansas City cardiomyopathy score as well. And so Impulse has data out where DAPA will hope to see those early in 2023. So now we'll kind of transition into the guidelines. This figure here is actually from the 2021 update to the heart failure guidelines. If you guys haven't taken a look at these guidelines, I would highly recommend it. Very straightforward, lots of pictures and graphs. So I love this with students and residents, especially when we're kind of doing some topic discussions. But you can see here at the top, I can get my cursor to work, we have our standard where we're kind of starting is an ARNI, an ACE inhibitor, or an ARB. And then I love how it says in parentheses, ARNI preferred. If you work with me, you know I'm a big Entresto fan, so ARNI is Entresto. So really we're looking at, should we have our patients on Entresto, and then also starting a beta blocker. So our metoprolol succinate, our carvedilol, or our bisoprolol. and then plus or minus a loop diuretic if needed for volume management. From there, that's where this kind of goes into what do we add next and in who. And so you can see the red highlighted box here are SGLT2 inhibitors. If your patient meets the kidney dysfunction or the GFR cutoffs and they have heart failure class 2 through 4, we really should be looking at adding an SGLT2 inhibitor. So it's really kind of that simple. When I'm thinking about in our HFrEF patient population who should have an SGLT2 inhibitor, I think of A, first and foremost, is it affordable? B, do they meet kidney criteria or what's their GFR? C, do they have New York Heart Association class 2 through 4? And really, if you say yes to those, you should be looking at adding this medication. Let's see here. So now we'll kind of transition into, see if I can switch. There we go. All right, dosing. So as I kind of highlighted in the clinical trials, if you can remember 10 milligrams, you know how to dose both Farxiga and Jardiance. So with both medications, we're starting at 10 milligrams, and our goal dose is 10 milligrams. So in terms of titration in the heart failure world, this is fantastic. With Farxiga, again, caution if their GFR is less than 25. And with Jardiance, caution if the GFR is less than 20. And we'll kind of elaborate a little bit more on the renal dosing here later in the presentation. In terms of administration, with or without food, so easy from that standpoint. A couple of things to just highlight. The potential for adjusting diuretics. So these medications, as we talked about with the mechanism of action and the pathophysiology, do have a mild diuretic effect. So we do need to monitor for hypovolemia and the potential to reduce diuretic doses in order to prevent dizziness or lightheadedness. I do have another slide on this as well, so we'll kind of talk more about this later. And then adjusting diabetes medications. So this is an area that a lot of us are probably like, ooh, I don't really want to touch any diabetes medications. This isn't our realm. And so my biggest thing that I always plug, and we do this in clinic all the time down in the heart failure clinic, is if the patient is on insulin or on a sulfonylurea by their primary care physician or their endocrinologist, work with those providers to help you. It's not something that we as cardiologists or cardiovascular practitioners need to necessarily do ourselves, and we can kind of utilize our resources and work through this together. So if a patient is on basal insulin, we need to potentially reduce the dose by roughly 20%. And if they're on a sulfonylurea like glipizide, glimepiride, or glyburide, we might potentially need to reduce the dose by 50%. And really where this comes about is SGLT2 inhibitors themselves are not going to cause hypoglycemia, but when used with other medications that do cause hypoglycemia, they have been reported to increase the incidence of hypoglycemia. So really when we're making these adjustments, it's to hopefully prevent hypoglycemia. So kind of keep that in mind too. If you have a patient with a hemoglobin A1C of 9, you're looking at adding an SGLT2 inhibitor, and their glucose in clinic is in the 200s or 300s, or we sometimes see even worse than that. An SGLT2 inhibitor is probably going to be very beneficial, and we don't have to worry about hypoglycemia. If their glucose control is good, or they tend to have hypoglycemic events already with their current regimen, that's where I'd maybe pump the brakes a little bit and utilize our resources, talk with our primary, talk with endocrinologists, and see how we can safely adjust medications so that we could use this beneficial class. In terms of monitoring, adverse effects, so polyuria, we can see dehydration and acute kidney injury. This kind of comes with that diuresis and natriuresis effect. As we kind of talked about, the genital urinary infections and increased risk of genital mycotic infections or fungal infections. So this was seen in the clinical trials and reported out. They did report, most trials stated that 75 to 85% of Patients who did have a genital infection only had one, but again, keep in mind the short duration of a lot of these studies were between about 1.5 years and 3 years for follow-up. So the biggest thing is kind of talking with your patient before starting these. So most commonly seen in women, followed by uncircumcised males, and then followed by circumcised males. So usually kind of how I approach this in clinic is I just ask the patient that we're seeing, one of the side effects of these medications, because of the increased excretion or elimination of glucose in your urine, is these genital infections. And so I usually just kind of say, have you ever had a urinary tract infection? Have you ever had a yeast infection, especially with females? And if you have a patient that has a history, we all know we have a handful of those patients that, get yeast infections every few months or recurrent urinary tract infections. Truthfully, these medications probably aren't going to work for them. And it's not to say that you couldn't try it, but no, you're probably going to run into further issues with these medications. They're usually mild to moderate. Patients that have a yeast infection or the fungal infection respond well to just our simple dose of fluconazole, so 150 milligrams for one dose. So if you can remember that aspect, if you do get a patient that does get the mycotic infection, that's kind of really the nuts and bolts of that aspect. And so how I think we can best avoid that with our patients is just simply having those conversations with the patients before starting. I always remind them too that if you develop symptoms of a urinary tract infection, make sure you do seek help, whether that's going to a minute clinic, an urgent care, your primary, whoever it may be, so that we can avoid the potential for urosepsis or pyelonephritis, because those are also reported out in the clinical trials. I wasn't going to touch a lot on canagliflozin or Invokana, but just remember, if you do have patients on this medication, it does have the risk of lower limb amputations as well. In terms of monitoring, keep an eye on renal function. Make sure we're following our GFRs, hypovolemia and volume status, euglycemic diabetic ketoacidosis. I have another slide on this as well, because this is something we have seen a fair amount of with the increased prescribing of the SGLT2 inhibitors. And then also foot care, as that is important with our diabetes patients, maybe not quite as important if the patient does not have concomitant diabetes. Contraindications, type 1 diabetes patients, there's an increased risk for diabetic ketoacidosis, so that's why we do not use these medications in type 1 diabetics. We do not have any data in lactation, and patients on hemodialysis should not be taking an SGLT2 inhibitor. Cautions are patients in pregnancy. Truthfully, I'd probably keep it simple and go more of an insulin route. Patients that have had ketoacidosis in the past that are diabetics. Patients with acute kidney injury with reduced oral intake or fluid loss. So just kind of think of if you have a patient that's got nausea, vomiting, diarrhea, on top of kind of the diuretic effect with their SGLT2 inhibitor, they're probably going to get in a dehydrated state pretty quick, and the kidneys, unfortunately, will be unhappy. And then we did touch on the urosepsis and pyelonephritis. So just looking at a few additional tips to remember. So these are kind of some things that I have found to be helpful and I find discussing with people frequently. So renal dose adjustments. Again, you can remember 10 milligrams. You know how to prescribe SGLT2 inhibitors. So with both medications, with Farxiga, so if their GFR is greater than 25, you can start at 10 milligrams daily. If you're looking at a patient to start Farxiga and their GFR is less than 25, it's recommended to not start the medication. But if you started Farxiga when their GFR was above 25 and then their GFR dropped below 25, you can actually continue with Farxiga until the time of dialysis. Once the patient requires dialysis, then Farxiga is contraindicated. In terms of Jardiance, if their GFR is greater than 20, their dose is 10 milligrams daily. If they drop below 20, then we don't have dosing data at this time, and it's not recommended to start if their GFR is less than 20. And same as Farxiga, Jardiance is also contraindicated in dialysis. So when looking at diuretic adjustments, this is something I wish if I had more time, I could do our own little site study of patients that we have started on SGLT2 inhibitors and look and see what our true diuretic dose adjustment has been. Kind of anecdotally, I will say for the general heart failure patient population, this is how I've at least recommended that we use the SGLT2 inhibitors. And so I always kind of keep in mind too, when we're looking at these patients, most of them are also on Entresto. So Entresto with that sacubitril piece also has a little bit of a diuretic effect. And then we also likely have our loop diuretics. And so adding an SGLT2 inhibitor, we're adding another medication that could potentially affect their volume status. So if a patient is euvolemic or dry, I tend to recommend empirically reducing their diuretic dose up front by up to 25%. And the reason why I say this is because I've seen and kind of heard between our, whether it's our heart failure nurse coordinators or LVAD nurse coordinators, that when we start these medications in patients that are already euvolemic or dry, they tend to call back within the first few days to a week and say, I feel like crap. This medication made me dizzy. This medication made me lightheaded. I don't want to take this anymore. And even if you try and explain, we might be able to make some simple adjustments and you'll feel better because you're likely just a little dry. They say, I don't want to use that. And then we now just wasted a potentially good therapy with these heart failure patients. So I like to say let's empirically reduce the diuretic dose in the euvolemic or dry patients, counsel them on, remember if you have 3-pound weight gain in a day, 5 pounds in a week, make sure you give us a call. Maybe we need to go back up on that furosemide or that torsemide and kind of just explain what we're thinking. If you have a hypervolemic patient, simple, kind of like if their blood sugars are high. No adjustment needed in their diuretics. The SGLT2 inhibitor will likely help you. Just to give a little plug with our LVAD patients, I always just kind of remind people that these patients are even more sensitive to volume changes with the pump. And so I think especially our LVADs that are already on Entresto, and then we add an SGLT2 inhibitor, we tend to see that some of these patients don't tolerate it as well. And you might be wondering why I have a picture of an engine with motor oil. And I've kind of found that explaining to patients with an LVAD and using kind of an engine as kind of the story of similar to your LVAD, that when we have our car and we have our engine and our motor oil, our engine cannot work within our car if we don't have enough motor oil. We always, right, fear the low oil light, or takes me back to my college days when I always had to put oil in my car. But I kind of explain that to patients as, you know, with our LVAD patients, we really say they need to drink 2 liters of fluid a day. And then we give the caveat, but don't drink too much more than 2 liters because then you're going to have too much volume. But, you know, this I kind of think of with our SGLT2 inhibitors, if we get that volume down just a little bit too much, then our engine light's going to come on. We're going to get low flow alarms on our LVAD. The patient might not feel well. And so kind of explaining it in that sense to patients tend to make it make a little bit more sense. And then lastly, I wanted to touch on the euglycemic diabetic ketoacidosis. So we have I've had quite a few questions from providers, and we've seen this down in the emergency department as well with the uptick in prescribing of these agents. And so just to kind of remind everyone, the definition of euglycemic DKA is euglycemia, so a blood sugar less than 250 with severe metabolic acidosis. So that's an arterial pH of less than 7.3 and a serum bicarbonate of less than 18, and then also the presence of ketones. So this is kind of tricky because when you think DKA, you think of like very high blood sugars. But where we really see this with the SGLT2 inhibitors is this euglycemic, so kind of more of a normal blood sugar. Clinical features, patients tend to just not feel well. And what that really means is nausea, vomiting, diarrhea, abdominal pain. Occasionally, they can be in a hyperventilatory state. Signs of hyperglycemia, so the increased urination, increased thirst. When looking at what we should order in terms of labs, a basic metabolic panel, so we should be looking at what's their blood glucose, their kidney function, so their serum creatinine and their BUN, their electrolytes, bicarbonate, and then assessing their anion gap. We should also be checking for urine ketones, because if urine ketones are present, then we should also be looking if there's serum ketones. And then lastly, checking an arterial blood gas, especially if the serum bicarbonate is reduced. The treatment is quite simple. Here at Abbott and within Allina, we have something called Endo Tool. If you haven't used it yet, I'd be kind of surprised, but you can always partner up with the internal medicine colleagues as well. This is a way that we can very carefully reduce their blood glucose in a controlled manner with frequent glucose checks. And actually just recently, the pharmacy team through P&T kind of updated some policies to get the addition of D5W fluids on these order sets because of the increased incidence we've seen with DKA. So this just kind of more safely can lower the blood sugar when giving insulin if we're using D5W versus normal saline. And then lastly, I wanted to leave you guys with a little bit of a mnemonic. If you studied with me in pharmacy school, I often had friends say right before an exam, Paige, what's your mnemonic? Maybe I'll get another test question right today. So this one I kind of put together, that's kind of fun. So similar, or this applies to Farxiga as well. So Jardiance, just always remember diuretics, insulin, and nephrology clearance. It's really that easy. So kind of key takeaways, diuretics, if you can remember that we might need to reduce the loop diuretic dose to prevent hypovolemia. That's one good step ahead. Insulin, remember our diabetes medications that can exacerbate hypoglycemia. So we might need to reduce basal insulin by 20% and also sulfonylureas by 50%. And then nephrology clearance, make sure we're following kidney function. We should be avoiding Jardiance if GFR is less than 20, and Farxiga if GFR is less than 25. But remember, you can continue Farxiga if the GFR is less than 25, as long as they have not started dialysis. And then lastly, we have our patient assistance programs. And so I'd first and foremost like to say, if you guys are looking at starting these agents in the hospital or even in clinic, definitely utilize our Heart Hospital Pharmacy and SAM and all of the excellent pharmacy staff there to make sure that these agents are affordable for patients. One benefit with Farxiga is patients can actually get their first month free. Unfortunately, Jardiance does not have that, but maybe with enough begging, we can get them to follow suit. As usual, commercial and private insurance patients are eligible for copay cards. So with Farxiga, you can get it as low as $0 per month. Jardiance as low as $10 per month. Both are covered on Minnesota Medicaid's formulary with no prior authorization, so that's nice. And just along those lines, Entresto is also on formulary now for Minnesota Medicaid, so that should alleviate a lot of headaches, and Sam's blood pressures probably came down quite a bit. As you can see, both medications and all medications in this class are over $500 without insurance. So again, really making the plug to make sure that we're assessing affordability of these medications before prescribing them, as oftentimes our patients are on other high dollar medications as well. And lastly, both drug companies, so we have AstraZeneca for Farxiga and Boehringer Ingelheim for Jardiance, also have patient assistance programs. So if they meet certain income criteria, they may potentially be eligible to receive the medication for free from the drug company. So that's always something to keep in mind. So in summary, just remember that guideline-directed medical therapy has changed. So we should be considering all therapies for patients with HFrEF or reduced ejection fraction. So we have our ACE-ARB or ARNI with preference to ARNI or Entresto. Our beta blockers, our aldosterone antagonists, and now we have another pillar here comes the SGLT2 inhibitors. So again, I just put dapagliflozin and pagliflozin here just because that's where we have the most data currently with heart failure. When starting an SGLT2 inhibitor, remember we might need to adjust diuretic dosing, so make sure we're assessing volume status. We might potentially need to adjust diabetes medications like our sulfonylureas or our basal insulin. We need to look at renal function and make sure we're following renal function, and then counseling on the importance of genital hygiene. So new kid on the block, Jardiance with our HFpEF patients with the Emperor Preserve trial. So if you're following patients with HFpEF, that's a good option that we should be considering. And then lastly, again, making sure we're assessing insurance coverage with both Entresto and the SGLT2 inhibitors, as they are quite expensive without insurance. So here are my references. And then if you have any questions, you can email me, all the forms of Epic messaging. I'm on Microsoft Teams. You can text me, even if I'm in Jamaica. No. And this is my horse, Stella, or as people hear me refer to her as Large Marge. That's her alter ego. So yeah, happy to answer any questions.
That was really good. Thank you for that masterful job. I want to just call out the euglycemic metabolic acidosis that you mentioned, because earlier this summer, Desmond J. sent out an email. I think everyone received it. And the important part about that was that the patient also had ST elevation on their ECG that looked like an acute inferior myocardial infarct.
Okay.
And that, Desmond had, just by coincidence, that will be published in JAMA Internal Medicine next week.
Okay.
Because the editors felt the ECG findings were important enough to, since we're seeing more and more of this, so
Okay.
that it might impact cardiology in ways that we never anticipated. So.
Okay. Yeah, I remember that email circulating.
Just in regard to the renal issues with SGLT2s, I know that in Credence and DAPA-CKD, both studies, they saw a bump in creatinine or a decrease in GFR when they started the medication, but then over the long run, they had preserved GFR.
Yeah.
You know typically how much of a bump in creatinine we see when we start these?
They say it's pretty minor, kind of where they say comfort level, and when I say they, in terms of the, the drug companies with the trials, is up to about 25 to 30% of an increase. And when you look at the renal studies too, if you follow kind of those curves with the creatinine and the GFR, it really takes about out to a year before those lines kind of cross and you see the benefit. So I always kind of remind people of that, especially when we're following, basic metabolic panels and their kidney function, that it's okay if you do see a little bit of a bump. Obviously, if it's a drastic bump above 25, 30%, then we might need to pump the brakes a little bit, but a little bit of a bump or a decline in GFR is normal, and over the longer period of time, it's actually beneficial. So that's an excellent question. Yes.
Can I just make a comment about cost?
Yes.
So a lot of the information, and correct me if I'm wrong here, Sam, a lot of the information Paige showed is related to patients with commercial insurance. When you have patients on Medicare, they have to often meet a deductible. And then even when they meet that deductible, this drug can still be anywhere from $37 to $47 a month. And the same goes for Entresto. So a lot of our conversations in clinic are around cost of these medicines. Because if I've got a patient who has to choose between groceries and pills, it's important to prioritize these pills. And if you have a low EF patient, I'm going to pick Entresto. So it's not, you just really have to keep the cost thing in mind. $47 a month might not be prohibitive for you or I, but for a lot of our Medicare patients on fixed income, it is. So keep that in mind when you're prescribing these.
Yes. Excellent point. And Sam, what's the deductible going up to in 2022?
$480. Oh,
yes. So every year it marches up, unfortunately. So for a lot of people, that $480 a year they don't meet without having a name brand medication. So obviously if they filled 1 month of Entresto or 1 month of an SGLT2 inhibitor, they would get there. But then exactly like Lisa was saying, for a lot of these patients, a copay of $30s to $40s a month is cost prohibitive. So even though it's quote unquote covered or they've met their deductible and it's covered, I think it's still important to make sure that that's something that they can afford. And navigating the patient assistance stuff. Because there is, you'd be surprised, a lot of patients qualify. It just takes a little bit extra work. Getting the thumbs up. Well, thank you everyone for hanging in Monday after Thanksgiving.